Can I just ask that everyone mutes themselves, please? Prof. Todd, I see you're not muted because there's a little bit of a sound disturbance. Okay. It's okay, Prof. I've actually muted you from this side. It looks okay now. The sound is gone. Okay, so I think we can get started. So welcome everyone. This is the noon meeting, our academic meeting. It's hosted by the Division of Occupational Medicine, which is a division that I work in. And it gives me great pleasure to present Thandi to you. Thandi is one of our MPH students. In terms of her background, Thandi is a UCT graduate who graduated with a first-class honours in B Business Sciences, Actuarial Science, and a distinction in stats from UCT in 2011. Following that, she began a journey to qualifying as an actuary, which she completed in 2015, and she's now a fellow of the Actuarial Society of South Africa and a chartered enterprise risk actuary. She recently graduated with a distinction from the MPH program at UCT, majoring in epidemiology in September 2024. She has over 13 years working in the life and health insurance environment and is an actuary in various roles. She's currently working as an actuary at Liberty Health and is also an assistant lecturer in the Division of Actuarial Science here at UCT. So Itumeleng and I were privileged to supervise the MPH project. And so she's going to be speaking to us about the socio-demographic and work-related factors associated with psychological resilience in South African healthcare workers. So, so the plan is for her to do a presentation and then we will take questions after that. Over to you, Thandi. Are you ready to see your presentation is loaded?
Thanks, Prof. Thanks for the lovely introduction. I just have a short disclaimer. Actually, Sarah home went off, so I've had to come to a restaurant to do the presentation because my laptop was dying slowly. So I hope you'll be able to hear me very well, despite the technological difficulties I'm experiencing this side. So our topic was socio-demographic and work-related factors associated with psychological resilience in South African healthcare workers. And this was my master's dissertation following completion of my MPA. So just a short presentation outline of what I'll be going through today. I will go through a short background on resilience and specifically why it's important among healthcare workers in South Africa. Then we'll look at the just a short summary from the review of the literature we did. We did two different literature reviews. One was just checking on systematic reviews that have been done on the topic. And then the other one was honing in on what actually literature is out there regarding lower middle income countries and healthcare workers working in this sphere. And then finally, we'll look at the cross-sectional study that we've conducted, just a high-level view of the methodology, statistical analysis, and key results and discussion from it. And then we'll have recommendations and conclusions. And then I've got the reference list at the end for those who are interested in it. So just a short background is just what is resilience. So this is the topic about resilience amongst healthcare workers is one that was very topical amongst the COVID-19. And specifically, psychological resilience is the inherent ability of one to adapt positively following adverse or stressful events. So the whole idea of psychological resilience has changed throughout time. And initially, we thought of it as a very individual, personal a term. However, with research and development in the area, we have identified it as a more of a multidimensional term, one that interacts with multiple systems and one whereby any one factor will have a different impact on any person. So we did find that most studies that are looking at healthcare workers, when it comes to resilience, they use the word adversity on it. So it is a very common word when it comes to definitions of resilience. And then why is it important for South African health workers specifically? So we do note in the bottom, again, thanks to COVID-19, the importance of resilience amongst healthcare workers was very much highlighted as they were the forefront and just the champions throughout the whole process. However, in terms of South Africa, resilience amongst our healthcare workers is important because one, we've got structural inequalities amongst the geographic distribution of resources within South Africa. And this is particularly thanks to apartheid regime that was active in South Africa between 1948 till 1993. However, besides that, we also do have quadruple burden of diseases, which results in high patient numbers in the country. And with this, we also see that there's a lack of finance and human resources overall. There's a few training institutions, and there's a huge shortage of healthcare worker posts. In 2021, we found that the doctor-patient ratio in South Africa was 80 physicians per 100,000 people, and this is much lower than the average that we find in other upper middle income countries in the world, at 210 physicians per 100,000 people. Other phenomena that we find impacting and resulting us wanting more resilience amongst healthcare workers in South Africa is the brain drain phenomena that is experienced by a lot of I'll use the word third world country, but a lot of our low middle income countries where we have a lot of our healthcare workers moving from our environment and up to the global north. We also are plagued with corruption and poor administration. And then overall, there's a lot of talk about NHI and just NHI and just the resources, I guess, not just financial, but also in terms of do we have enough healthcare workers to be able to make NHI work for South Africa? So just before we get into the literature, I just want to highlight a few things about measuring resilience in practice. So we find that there's no gold standard in terms of measuring resilience. You can find the different research literature out there. Different researchers use different tools to measure resilience. Usually it's via questionnaires, which are either self-administered or administered by a trained professional, but most of the literature you'll find is a self-administered questionnaire. And that's also talking to our research as well. And the tools used depend on the study population that you're looking at, whether it's an adult versus children, the cost and the resources available to distribute the tool, and then just the overall budget and the time frame you're looking at for the study. And then just to highlight as well, why it's important to look at the tool that's being used for measuring resilience is that different tools do lead to inconsistent findings. And this makes it difficult to compare. So if you have a paper on resilience, you need to make sure that the stats and the conclusions being included in that paper are, and you compare them with other papers that have the same resilience tool underlying the whole measurement. Or else you'll be comparing apples and oranges, basically. So for our paper, we specifically use the Connor-Davidson resilience scale. Particularly, we do find that this is one of the most widely used measurement scales for psychological resilience. And it's because it's very easy to complete. We use the CD risk 10 version of it. So it's only got 10 questions and it's got high internal consistency and reliability. And it's also been validated in South Africa and many other populations. So it does make comparability of our results versus other results much more easier. And then something to also bear in mind about the Connor-Davidson resilience scale is that there's multiple versions of it, the original being the Cedar Risk 25, which is 25 questions. And then there's later versions like what we use in our paper being the Cedar Risk 10, which only has 10 questions, meaning the score is out of 40. So from 0 to 40, given you're using a 5-point Likert scale with 10 questions. And then there's other versions, of course, as well. And then also just to highlight before I move from the slide is that the CD risk scale is also easy to use because the authors have recommended cutoffs. So particularly for any CD risk scale, the CD risk 25 and 10, you can use the quantiles at cutoff, and that's converting the resilience score into a 4-level variable. Or you can, for the CD risk 10 specifically, use a 2-level variable where you use 25.5% as the cutoff, and that way you're using it as a bivariant variable, and you can use it then to do logistic regression analysis following. And then just looking at the literature, so the first literature search we did was looking at the systematic reviews that have to do with resilience amongst healthcare workers, irrespective of a location or the tool used. So we found 10 systematic reviews that were talking specifically for resilience amongst healthcare workers. And from this literature search, we saw that most studies published prior to COVID-19 originated in high-income countries. And that most of these studies did use the city risk scale, which further validated our use of it for our study. And then following, we saw that the resilience of nurses, specifically the nursing population, was a subject of much past research, and this is because of the global nursing shortage that is not only experienced in South Africa, but other countries as well. So 4 of the 10 systematic reviews we saw were focused exclusively on nurses, and then a further 2 of them were looking at the implications of resilience for nursing management. So once we finalized the systematic review, this literature review for systematic reviews, we then decided to hone in on what literature is there actually available on healthcare workers in low middle income countries, excluding nurses, and using the CIDR risk scale so that we can ensure that the results within the literature we've collected are comparable. But before I move there, I just want to highlight some of the positive predictors and negative predictors we found from the systematic review. So specifically, we found that things like self-efficacy, support with a family or colleagues, physical activity, hope, growth, and just a social network, those contributed positively to high resilience amongst healthcare workers as per the systematic reviews we identified. And then some of the negative predictors are workload, stress, burnout, things having to do with COVID-19, not having enough knowledge, not having enough safety protocols in place, emotional exhaustion. So particularly that both personal and organizational factors were highlighted as important. So more talking towards our later definition of resilience, not being just the personal and individual characteristic, but also having to do with the environment that you're working in, specifically then also looking at the workplace that we find healthcare workers working in. When we look at the review of literature looking at specifically low middle income countries, studies that were done using a low middle income country cohort, this was also done on the last search was done on the 22nd of August 2023, so similar to our systematic review search. And we started with 636 English journal articles, and we ended with 22 journal articles. Particularly, before we got to the 22 journal articles, we removed 74 nursing studies. So because our mandate and our objective was to look at the non-nursing population, eventually we removed those 74 studies and ended up with 22 studies that were looking at either a mixture of healthcare workers or specifically honing in any one of the other practice areas. So something to point out from those 22 journals that we found that prior to COVID-19, there was little research on healthcare resilience amongst healthcare workers in LMICs. Particularly, there are only 2 pre-2020 studies, one being GPs in Cape Town and the other one using China as China healthcare workers. And then also from these 22 journals, from the 20 journals, we found that most studies originated in China. So out of the studies we had, 12 of them were from China. And then overall, we found that the weighted average resilience using the CIDR 25 score was 63.5 out of 100. And then using the CIDR 10 score was 26.0 out of 14. And then just to remind you, the bivariant cutoff I mentioned earlier on, which has nothing to do with the dispersion, was 25.5 as per suggested by a research article by Yi et al. So using that 25.5 cutoff at an average of 26 for the CIDR 10, we can see that overall, given the studies that have done, healthcare workers are slightly just above the cutoff into the high resilience space. So the next few slides, I'll be going through just some of the factors we've identified following the literature search of LMICs, and then we specifically use a socio-ecological model framework just to summarize the results. So this is just a framework that is used a lot when it comes to just honing in and trying to systemize factors. And other authors have used this framework for looking at factors that have to do with resilience. So specifically now, this is just a high-level overview point where we have risk factors and protective factors both there. Looking at the socio-ecological model I've mentioned already, we've got personal, workplace, and then we just added a line called COVID-19 pandemic specifics under the protective factors, because that was a theme that we saw generally coming out in a lot of the post COVID-19 papers. And then the last one is just looking at policy factors, so the overlay, the outer area of more socio-ecological models. Sorry. So then you'll see there's a wide range of what is it, differential, wide range of types, looking at personal, where we've got the gender, which is also another thing we'll talk about later, given the results we got. We've got general and mental health coming through, stress under personal risk factors, and then under workplace risk factors, you'll see things like workload, workplace bullying, and injustice. For our protective factor, I'll just highlight from the COVID-19 pandemic specific ones, which we've mentioned already, given the systematic review overview, and that's your just having COVID-19 knowledge, well-being, perception of safety, and having protective material that have to do with COVID-19. And specifically, I guess, also under policy factors, because that's something we won't see again because we didn't look at it in our cross-sectional study. Just noting that, pandemic preparedness of the country came through as an important point when it comes to protective factors, when it comes to resilience amongst healthcare workers, and then also just the overall healthcare system support that's there and the strong educational system of the country. And then now we go into our cross-sectional study that we've conducted. So just a brief highlight before I get into the results of what our study rationale is. So from the literature, we've seen that that the role of psychological resilience as a protective factor in frontline healthcare workers is increasingly being highlighted, and it's specifically very important given the pandemic it just went through. However, research in this area has mostly been conducted in high-income countries still, and in China mostly when we're looking at LMICs. So there is a definite need to look at what resilience means for healthcare workers in other LMICs, particularly including South Africa. And that's why our study, we looked at determining just not only the prevalence, but also the factors associated with psychological resilience of healthcare workers practicing in South Africa. So just a brief overview of the methodology we followed. So we used secondary data specifically from two previous studies. One was looking at ambulance personnel in the Western Cape province, and then the other one was looking at medical doctors in the Eastern Cape province. Ambulance personnel, I received that from my supervisor, and then medical doctors from a colleague within the occupational health space. There were 647 participants overall. 259 of them were the medical doctors, and 388 of them were the ambulance personnel. And then participation specifically was voluntary, and we required our participants to complete an electronic online self-administered questionnaire. Our response variable, as mentioned, is the CDRISC-10 score. And for this CDRISC-10 score, as mentioned, there's a lot of ways of looking at the CDRISC-10 score. We did high-level evaluate what would it mean if we use either of them. For example, if we were use the quantile approach, which results in a 4-level form, meaning we're going to use a multinomial logistic regression. We found that we didn't have enough data to look at this analysis. So we looked at like multilinear regression as well, which we have submitted results with that. However, what I'll be looking at here is our results from the Mann-Whitty and Kruskal-Wallis test, which is our bivariance analysis. So looking at the average resilience scores without making any adjustments for other factors. And then also looking at our multivariable logistic regression analysis using that same cutoff of 25.5% I mentioned earlier on. And then just to mention high level before we move on to the Mann-Whitty, Kruskal, and the logistic regression, overall, the results were very much consistent no matter the method we use, albeit barring the multinomial logistic regression, which we didn't have enough data for. However, we did find that the same conclusions were there. And in terms of the salary that I have highlighted, salary was significant still, but then we did see a reverse reaction when we use the linear analysis, but that's for another discussion another day. Particularly though, to highlight, we did look at missing data analysis, and we then imputed the age variable as it had a missingness of about 5%, and we used the classical regression tree method in the mice packaging R. And then of course, ethics approval was obtained for the study. So when I look at results, in terms of looking at the participant characteristic, we do find that underlying, we do have different types. The participant characteristics of our doctor cohort versus the ambulance personnel differ slightly. Particularly, we found that there were more males under the ambulance cohort versus our doctors cohort. The doctors tend to be much younger and they tend to experience more overtime. And of course, they have a higher monthly salary overall. These factors are gonna impact on the average resilience score that we're going to see. And then we've got a slide separate for that. Then just to highlight quickly in terms of substance use and mental health, we did find that our ambulance personnel, ambulance personnel tend to have a higher percentage of never, oh, no, sorry, doctors tend to have a higher percentage of never use versus our ambulance personnel. And then slightly reversed relationship when it comes to alcohol, but the difference is not really that struggle as what is the highlight. And then in terms of mental health, found that doctors with slightly higher percentage of having had a diagnosis for mental health versus the ambulance personnel, and that also in terms of current treatment for mental health conditions. So the results, specifically looking at the resilience score, the average resilience score for our cohort was 27.6%, so slightly higher from the 26% we saw in terms of our literature review when we looked at the LMIC data set. But then particularly in terms of our ambulance personnel, they had slightly higher resilience versus our doctor personnel, our doctors, and that was significant using the Mann-Whitty analysis. And then again, just highlighting the reason for this was because we found our ambulance personnel were not only older, but they were mostly male and they had longer years of service. And then they also worked less overtime, which given the next few slides, you'll see these are all factors that result in higher resilience being found in said individuals. But then just to highlight though, overall the results that we found in terms of our average resilience score was very much comparable to other studies, especially when we take into account the standard deviations of the scores being reported. Our 27.6 always fell in between those standard deviation bounds, even though it was either higher or lower than the average that was being reported in the various studies. And then this is just also same idea of summarizing as we did in the literature review of our LMICs. So using the socio-ecological model, these are the factors we found given our cross-sectional studies to be either risk factors or protective when it comes to resilience amongst the healthcare workers in our study. So we found that actually, there's slides coming in that will specifically hone into some of these, but then I want to just highlight, we don't have a slide on high salary, but please bear in mind that high salary was found as protective amongst healthcare workers in our cohort. And then just, I guess, discussion points about the positive factors. So the first, I guess, factor we are highlighting here is current smoker. It had an odds ratio of 0.16, very significant CI, and this was specifically for our doctors cohort. And you did note there that our doctors, percentage of them, there's a high percentage that did not smoke, current smokers, when we were just looking at the overall demographic split. And we did kind of rationalize this, that, you know, current smoking, it may reflect a coping mechanism, and that could mask low levels of resilience, which is why current smoker might come through as a positive factor, so protective towards low resilience in this case. And then if we look at previous alcohol use as well, came through as protective, and this was particularly probably because previous alcohol use means you low risk when it comes to relapse, and that is usually associated with greater resilience. And then it makes sense why people who have previous alcohol use tend to be more resilient than people who are either currently using alcohol or have never used alcohol. And then just particularly to highlight is that we did find studies reporting that substance use and medical use have been used as maladaptive coping mechanisms overall to address mental health issues and work-related stress specifically. And then looking at negative factors, So negative factors, the one mostly recognized in the literature we looked at was females. And we also did find that, being female resulted in a higher risk and a higher likelihood of you showing as having low resilience. And we found an adjusted loss odds ratio of 1.94 in our cohort. And that's looking at our doctor cohort. We find that this might be because females tend to play multiple roles at home and in the workplace, but also in the other side, your males tend to have social desirability bias. So they might be motivated to answer in such a way that it does show that they have better coping mechanism and i.e. higher resilience coming through in terms of the data we have collected. When it comes to mental health diagnosis and treatment, we do note that there tends to be underreporting of this in research studies. And then we did find that, mental health diagnosis and treatment are also negative factors. And unfortunately, this could be a stigma and denial related to mental health, particularly looking at the lack of trying to seek treatment for the condition. And then lastly, on this slide, we see alcohol use for managing work-related stress, and then just that resilience tends to interact with stress to impact on the development of addiction and relapse. Then just a highlight now on the workplace specific factors. So we have job category. Job category coming in at the odds ratio of 6.94. So it's coming through as a risk factor. And we did find here that it was mostly linked to seniority in doctors. So our senior doctors coming through. And this might have something to do with just exposures to patients and their families coming through. So job category tends to come out a lot as a risk factor when it comes to resilience. Particularly studies that are looking at the nursing population tend to see that nurses have lower resilience because of mostly the touch points they have with patients and their family members relative doctors when you're looking at that kind of study. And then finally, just to highlight, when it comes to overtime worked, we found that was a risk factor. We had an odds ratio of 13.88 amongst our doctors. And just that, when you're overworked and you're working a lot of overtime, you tend to have low job satisfaction, just overall poor work performance. And then this results in a high job turnover for healthcare workers, basically creating a vicious cycle that would ultimately lead to some burnout or low resilience. And then just some strengths on our study we found. So particularly for a study, we did follow a multidisciplinary approach. So we had a mixture of occupational health professionals and myself and actually. So we tried to leverage on each of our experiences and expertise. So we found that was a particularly strength for our study. And then we also did find that in terms of the surveys we had and to collect our data, we had a good response rate. And particularly, we had a large population of healthcare workers in our study. And of course, we used the CD risk score, which was a validated tool. And then overall, we did try and use validated and standardized questionnaires to measure our not only response variables, but the other variables within our study. Just the limitations of this study. Of course, we did use secondary data, meaning that we are limited in the variables that have been collected in the past. It is a cross-sectional study, meaning you cannot do causal inference from it. And then we did use self-reported data, and there might be a little bit of selection bias given the voluntary nature of the data collection. And then the health worker effect that comes in whenever you're collecting data at any one specific point in time. And then just some recommendations and conclusions we found, we left our study with is that, research on psychological resilience for non-nursing healthcare workers operating in low middle income countries is limited and contradictory. And yes, it's picked up since COVID-19, but this is still mainly conducted in China and I guess still in health income countries. So there's not really a wide variety of options of different LMIC. And then resilience for our specific population, it was relatively low. However, within bounds, of course. And then we just wanted to highlight that we do need to build resilience of female healthcare workers specifically, especially if you have resource constraints, so you can't look at resilience overall for all your healthcare workers. So we are advised that you look at female healthcare workers that are working long hours or earning lower income than their other counterparts. Particularly, we just highlighted that psychological counseling and support is specifically needed, I guess, to help diagnose mental health conditions or support healthcare workers working within South Africa. And just overall, we do want a call for action that additional research is needed, specifically focusing on resilience amongst healthcare workers in South Africa. This would particularly be looking at a larger and more representative sample, and maybe using qualitative research methods that could probably pull in a lot of other factors that you're not able to look at when you're doing a quantitative analysis like we have in our study. And then this is just a slide of the references that we collected. And I will pause for questions at this point. I hope I haven't lost people. I cannot see anything with the sharing.
Thank you, Thandi, so much. The floor is open for questions. Lots of applause, I see.
Thank you.
Please raise your hand if you have a question. If you could also just look, I see you on Gavin Reagan. Please go ahead. Unmute yourself.
Thanks a lot, and thanks, Thandi, for a great presentation and a wonderful study. I just have two questions. The one is a simple one. I may have missed it, but what was the response rate to the questionnaires? I might just have missed that. And then the other one is, I'm just wondering why you chose to do emergency medicine practitioners in the Western Cape, but doctors in the Eastern Cape. And don't you think that the context might have affected the results, and especially comparing between the EMS practitioners and the doctors? Because, of course, circumstances were quite different in the different provinces. And also, as you mentioned in your literature review, the organization's response to COVID was also important. And that was quite different in the two provinces as well. And of course, the staffing levels for the various categories in the two provinces are also quite different. So I'm just wondering why you chose that, and how you would use that context knowledge to interpret your findings. Thanks.
Thanks, Gavin, for the lovely question. So in terms of our medical doctors, we had a 260 out of 430 potential doctors from the hospitals we were looking at in the Eastern Cape. In terms of the Western Cape, I cannot really give you a specific percentage there. However, we were very satisfied about the response rate we got from collecting that data. I think because we were doing a secondary data analysis, we had these two cohorts. However, that's why we try to look at them as separately as possible in order for us to make sure that any differences between the two cohorts, given that we're looking at different provinces and different practice areas, those differences were not impacting on the final results that we got from our studies. So we looked at the combined results just to get some power from it, but then we also did look at the different cohorts separately, just to bearing in mind the unique differences between the environments our cohorts are working in. I think what we found specifically when we combined the two data sets is that we had some factors coming through that were subtly coming through only when we were separating the two different data sets. So we thought it was necessary to highlight those impacts, like mental health diagnosis and treatments, were coming in when we put the two data sets together. And we know that mental health tends to be very underreported. So that might be why we're not seeing it when we're separating them. However, we did appreciate the differences between the two cohorts. I'm not sure if I'm missing another question that you gave.
No, I think you've covered it, Thandi. Gavin, are you happy? These are two separate studies. They have been conducted separately in different, and I think you raise a very valid point in terms of context. I think that the EMS study was also done pre-COVID, and the other one was sort of done during and post-COVID. So I'm sure those are all factors that do influence the results. I'm going to ask Orly Nelson to pose a question. I see your hand is up. Do you want to go ahead? Please mute yourself. Unmute yourself and ask a question.
Good afternoon. Thank you for the very interesting presentation. I might have missed it, but I was also wondering if you'd assessed exercise like physical activity and if that could be a protective factor in your questionnaire. Thank you.
Unfortunately, we didn't look at it in terms of questions we collected. However, lots of literature comes through to say that yes, exercise is a protective factor when it comes to low resilience. So I reckon, you know, if there's a follow-up study, we would really motivate for that to be one of the data points that is collected. And of course, bearing in mind, I guess, when it comes to physical activities, how you measure it definitely depends on what results you're going to get. But unfortunately, we didn't for the study. Thanks, Ariel, for the question. I think you can go ahead, Siki.
Oh, sorry. Thanks, Thandokazi. In fact, Gavin, yeah, I think covers many of my questions. Again, I mean, it was a lovely presentation. So what I'm keen on, one is to understand what was the primary intention of running that survey. Two, to what extent, you know, would that have influenced your findings? And also, I'm keen to know what were your limitations when you were analyzing your results?
Thanks, Sigi. Oh, yeah,
Thank
I did not highlight that. So the medical doctor study was initially collected in order to determine just the level of burnout amongst medical doctors in the Eastern Cape, and then the Western Cape ambulance personnel was looking at PTSD amongst ambulance personnel in the Western Cape. So they both had mental health related reasons for the data being collected, and we do anticipate that the reason for the data to be collected primary might have motivated, say, people who have PTSD and burnout to be more motivated to responding to the initial survey. But then we were hoping that that would not filter in through to our final results. So yes, the primary data collection was for specifically different purposes rather than evaluating resilience. And I think that's why, like, one of our recommendations is that we do recommend that people specifically look at resilience amongst healthcare workers, because it is an area that we really need to put more resources and concentration towards it. Then, like, our limitations, we found it was secondary data that we were looking at. It was unfortunately a cross-sectional study, so there's only so much you can do when it comes to causal inference. And then just also the other reasons why our data, the reason why the primary data collection happened, that could result in people voluntarily participating because they either have burnout or PTSD. And then we always have the health worker effect whenever you collect data at any specific point in time.
Mm-hmm. Okay, all right. Thank you for that. I mean, you have already raised the fact that one could explore this further by doing a qualitative study, and I think there's a space for that. Because I mean, if you're looking at the experiences of females, they have multiple roles, but the one aspect that we don't speak too often is patient perceptions to who should be their healthcare providers. And we know that, I mean, there's anecdotal evidence where, you know, your younger females have to negotiate as healthcare providers, you know, because, you know, one is already making a judgment call about who they are and have different expectations of who should be. And so it would be interesting if someone could pick that up and explore that further. But thank you so much for your study. and and also to your co-authors.
Thanks.
Thanks, Nancy. I think if anyone on this call wants to do a secondary study, we will happily join and participate in helping with the statistical analysis or anything required underlying that. I think, yeah, it's definitely an area that needs to be investigated and researched on further. Thank you.
Thank you.
Thanks, Thandi. So Thandi is a bit of a whiz with statistical analysis. She needed no support from both supervisors, I think, in doing that analysis. So there she's opened herself to further requests. I think Gavin has done, Gavin just commented that because of the different response rates amongst the two, I don't know if you can see, Thandi, 60% response rate for doctors versus 24% response rate for EMS practitioner, different provinces, one pre-COVID, one post, makes comparative interpretation very difficult. So it's actually 68%, Ito said. Ito, do you want to comment? Because you are the primary investigator for the one study and really the primary supervisor for Thandi's study. Maybe just a comment from your side.
Thanks, Prof. Yes, I think you have covered the main concerns, but just to add to what Thandi has said, that initially part of the two studies, the main outcome of interest was PTSD for the EMS personnel study and burnout in the doctor study. The CD risks scale was obviously used as one of the predictors, or at least to elicit one of the, or at least to act as one of the correlates or the predictors. And what we found in both studies was that lower the rates, or at least the level of PTSD or PTSD diagnoses, was associated with decreasing levels of resilience, and similarly for the for burnout. So and I think that was what resulted in our interest in the in trying to then ask a question around what really in our own setting would be a determinant for resilience. And I think what is coming out is already giving us some indication of areas or potential areas that one can focus on in supporting healthcare workers, but also in looking at reforms, or at least organizational measures that should be put in place as well. So we did, in, of course, designing the study, understand that the limitations that Gavin has picked up on would certainly be a concern. The response rates, the issues around the different contexts, but in our own setting, where there is, as probably you've seen with Thandi's research of her literature, in our own setting where there's very little that has been done using a validated tool to measure resilience, we thought that it would still be beneficial to look at these factors. Thanks, Prof.
Are there any other questions? Anything? Oh, Mohammed, please go ahead.
Hi, thank you very much, Thandi, Itumeleng, and Shahida for this interesting study. Notwithstanding the limitations, I think it is an important aspect to highlight, because as we all are aware that the problem certainly exists. So having said that and recognized some of the limitations of your study, should you decide to design a new study, what aspects would you focus on and how would you do things differently? Thanks.
We've actually touched and actually spoken about this in passing, just looking at, I guess, the recommendations that we thought might be specific. Just that, given we did a very quantitative study, we thought looking at qualitative study would be a very added bonus if we were to do the study again. And particularly there are factors like, why are females less resilient in most studies? Why are they coming out as less resilient? You can only find and determine that by specifically asking questions related to that and honing in on the actual reasoning behind the factors that you're seeing coming through. And I think that's the one step further for us to actually put in strategies and just adopt new ways of doing work. is to find out why are these factors coming out as important to low resilience, and that you can only do with a qualitative study and sitting down in the cohorts that you've identified and just finding out from them is what I guess keeps them up at night in a sense.
So if I could just add to what Thandi is also saying, I think part of it is if one was to look at a cross-sectional study within our own setting, I think the use of the tool was quite strengthened, the correct one of using the CD risk score. But of course, as identified by the colleagues in the room as well, it would be important for us to include a wider array of healthcare workers, and also have a much more representative sample within our setting. So at least covering, if we had lots of money, covering most of the provinces within our own setting. We certainly don't have some of the larger groups of healthcare workers, including the nursing fraternity, for example. We haven't looked. I think one comment that did come up following our publication of this study as well from Prof. London, rightly so, was that we haven't included other healthcare workers, including community healthcare workers, in the broader definition of in our broader study population as well. So those would be changes that one would have to look at in refining at least the cross-sectional study component of the study as well. Thanks.
Thanks, Ito. So
Thank
I also
you.
just want
Shaida?
to,
Oh,
thanks.
okay.
Yeah, I also just wanted to comment. Mohammed, do you have another question, or can I go ahead and comment?
Please comment and then I'll respond. Thanks.
Okay. So I think the other thing for me that stands out from this kind of research is that resilience often seems to be located within the individual worker, who has to somehow up their resilience or develop more resilience or whatever. And although we asked about work-related factors, I think that future studies should look at organizational factors that's contributing to those kinds of outcomes, because I think there's a tendency to focus on the individual, what the individual has to do, without necessarily looking at the system. And certainly with Itu's study, I think he had lots of ComServe doctors, lots of interns, because they make up the bulk of the with Sajda's study on burnout. And all those factors, may play a role. All those factors in terms of their working conditions, interns' working conditions may play a role rather than just the intern themselves. So I think there is a danger that if we don't look at that a lot of pressure gets put on the individual worker to kind of get better, develop more resilience or whatever, without looking at, as it were, at the whole sort of ecosystem in which they're working. And so qualitative components would be good, but also tools that could actually measure that sort of organizational factors, in a validated way, I think would also be useful. And then I just wanted to comment on the response rates. It's two different studies. And, I think Ito studied the EMS, they are highly mobile people. I think we tried doing it with an electronic survey, which was a disaster. And Ito actually had to physically go in and administer questionnaires to get the data. So highly mobile, it's healthcare workers in general are the difficult population to study. There's stigma, particularly with mental illness. Maybe not many people are going to say they do have PTSD or they're at very high risk for PTSD. And one needs to sort of look at ways to manage that better and think about it before you embark on further studies. With the study in the Eastern Cape, it was an occupational health doctor based at Livingston who did the study. She had access to a lot of the people who were actually coming to her with burnout. In fact, that is what spurred the study, that a lot of people were telling her they're not coping. It was during the time of COVID. So heightened awareness, maybe a heightened need to report and to seek help. And so that all might have influenced that sort of response rate. Yeah, Mohammed, you can go ahead. That's really just more comment from us.
Yeah, thanks very much. I think the points raised and the responses are part of the aspects that I wanted to highlight. I do think that qualitative study on its own is not necessarily the way to go by virtue of the issues we've just mentioned around representativity as well as response rates. So if one were to focus on an epidemiological study, does one not think that longitudinal design may actually be a useful one with regard to assessing things by virtue of issues around substance use and abuse? They can be both a consequence or a risk factor for some of the psychosocial problems. And secondly, given that we have such a large health worker population, even in one province, is there no way to do such a study which is incorporated into the routinized surveillance of health workers? That's my one point. And then the second one is there an easy instrument that one can use perhaps through through a phone, a smartphone that people can do, which may be self-administered? So those are my two questions. Thanks.
But I think, yeah, longitudinal study would assist a lot, especially considering just the research around resilience and just how it can change when you reach different life stages. So if you were to follow someone between two different life stages, then you'll be able to try and figure out just is that impacting it or not. I guess longitudinal study also has that con of follow-up rates. It's hard to keep them up, especially amongst your doctor population, which might be changing hospitals and might lose contact of them, or in our case, might even leave the country. So impacting on the numbers of people you can actually report on at the end of the day. I think something like an app or putting it as part of the occasional data collection from healthcare workers, that could be something that would be very beneficial, basically normalizing the idea of thinking about your resilience and being more active towards self-reflection on what you're doing or what is impacting on your resilience stage. And also, I guess, just what level of resilience are you at as a healthcare worker working in an environment that you might be working in South Africa. So I think it's something we just need to try and motivate more from the different associations working with healthcare workers of trying to put in tools in place in order for healthcare workers to reflect more and to also be more aware of their mental state and their levels of resilience overall. But yes, no, I think that'd be a very good idea. Thanks, Paul. I do just want to take this time to thank my supervisors. They've been very great throughout this whole process. So thank you very much, Shaida and Itu Milan. Really appreciate it a lot, all your help.
Thanks, Thandi. Prof, I think it's over to you.
Oh, sorry, I'm speaking to myself here. So thank you, Thandi, and thanks to all of you who attended. I hope it's been a great discussion, I think, as well as presentation. So we will leave it at that and say goodbye to everyone. Thanks.
Thanks so much.
Bye-bye.
Thanks and bye.
Bye, everyone.